I did want to reintroduce Judge Taha. She was here earlier. She wasn't putting anybody away. Right, yeah. She's from Scandia. I know a lot of you go there frequently. So. Okay, let's see. 2:15. Yeah. You're gonna, that's you, right?
Claudia. No,
oh, Marcy's here? Francisco?
Mm-hmm. Yes. Yes, she is.
Oh, good. Thank you. Send her, it is, too. Well, we're going to take this next panel to talk about wellness and preventive medicine. And, you know, we were always told that, well, you know, if you never get sick, you're going to save a lot of money. And that sounds like a great idea for somebody in politics to go out and say, oh, I'm going to be for prevention and wellness, and that'll get me reelected. But anyway, it is a very important thing, so we're going to have some talk about that. And let's see now, I'm going to need Claudia. No, I just need. Claudia's substituting, right? She's from Wichita and going to help us out today.
Yes.
Claudia Holmbaum, who's the Assistant Director of Healthy Kids Challenge. It's a unique program that helps develop. Are you Claudia?
Yes. I am.
Yeah, I know it says that in here, but it says Dighton. You're from Wichita.
I'm from Wichita.
Yeah.
Yes.
She was from Dighton, but now she's. Anyway, she's here, and they have this very unique program that about diet and exercise, that habits in kids, and then we're going to have Arnitha Martin, who's co-founder of the Center for Health and Wellness, right?
That's me. Right.
And also Lieutenant Colonel in the Reserves, and from Wichita, and we've met before. And then Ned Holland, who got the shot of cortisone for his back, and we're happy to have him as Senior Vice President for Human Resources and Communications at Embark, based in Evelyn Park. And he's going to sort of give us the employer's perspective, how he looks at all of this on wellness and prevention. So Claudia, we're going to start with you.
It's a huge honor to be here today to share some of the lessons learned that we've had in working with schools, programs, and communities. I'm going to be describing a program that was 3 years, so I'm really going to flip through charts here today and through the slides. Healthy Kids Challenge is a nationally recognized nonprofit that is Kansas-based and led by registered licensed dietitians. We have over 11 years of service in helping schools and communities with evidence-based best practices. I'm here today to talk about a specific initiative, one of 15 different initiatives that we have going on around the country. And this one is Kansas Kids Can Connect. CAN stands for Connect Activity and Nutrition. And it was a grant that was funded for 3 years. Actually, we're just wrapping up the third year right now. Funded by the Sunflower Foundation, Healthcare for Kansans. It was designed to build the capacity of existing youth programs in schools to integrate healthy eating and physical activity into existing policy, program, and practice. This initiative is impacting 10,000 kids over 16 counties in southwest Kansas and involves 50 different schools and community youth programs, and as I said, for a 3-year initiative. Why did we pursue this grant? Well, the obesity, the overweight issue is one of the obvious reasons. Not quite so obvious is that a majority of Kansas kids as well as American kids are not eating healthy and not getting enough physical activity. The problems that we see in western Kansas are the same as we see anywhere. The lack of time, the less than optimal staffing, and lack of funds to really engage the youth leaders and teachers. A unique challenge in western Kansas is the fact that there are a limited number of healthcare professionals to support and help to create these healthy changes. What were some of the CAN, as we affectionately call it, solutions? First of all, we targeted multiple environments. We recognize and we support that schools are an important environment. However, they're very challenged with all that they have to do. So we don't want to lose sight of how important other youth programs, community programs can be. We also focused on building capacity with KidLinks. KidLinks are what we call adults who can help kids make healthy choices a habit. Building capacity meant engaging teachers and youth leaders and also helping them with the kinds of strategies that would have the greatest impact. We used a 5-step process to build a foundation with these schools and community programs, and also used 5 different key strategies that I will go through briefly. The foundation for change was created by forming, first of all, local partnerships, because there isn't a lot of support. That peer support, that local support, and mentoring were very important, especially in western Kansas. The Pioneer Health Network, an existing hospital network, was one of the key partners in all of these communities to facilitate communication and collaboration. We required the participants of the grant to attend training and to use new teaching tools and resources in their programming. There are a lot of resources out there, really great resources. We used them all. We chose a select number and gave them some hands-on experience because they tend to be overwhelmed with where to start. So that hands-on experience was important. And then to keep them engaged, distance assistance and support was also helpful. Celebration is obvious. The celebration was very critical in motivating these programs. They were just really pumped up at our last meeting to share all of their successes, and you could just see the pride shining through in the things that they have been able to create. We used 5 strategies for change, an assessment, an action plan, helped them to develop staff wellness, gave them a common purpose to rally around for collaboration, and use consistent repetitive messages. I'm going to spend just a little bit more time on each of these 5 strategies. Developing these grassroots efforts was really important to do that assessment, and these are some of the things that they looked at in their schools and their community programs. Creating an action plan is important for all the obvious reasons. If you're working in a school or a community program, you don't always have time to really sit down and do an action plan, so we really had to encourage them to do it, an important part of communication and collaboration to get more people involved. Staff wellness, extremely important. We concur with James Bogdans, who is the National Association of State Board of Education, involved with them, and that school staff wellness may be the key to impacting a healthy school environment, but not only a healthy school environment, but a healthy program environment as well. We found that National Hospital Week was a very popular event in western Kansas, and it gave us a great rally point around which to build that collaboration and that mentoring. And we heard this over and over again from the different programs. You see in front of you a few of the really creative things that they really came up with to help to make National Hospital Week more interactive than it had been in the past. We focused on healthy behaviors rather than on weight. We do have an obesity crisis, we have an overweight problem, but we want to make sure that the pendulum doesn't swing too far in the other direction. And it's important for kids to focus on healthy behaviors. And so in front of you on the screen, you see the behaviors that we selected. The first 3 are recommended by Centers for Disease Control as a part of Healthy Americans. What were some of the results of the actions that were taken? We felt like we really succeeded with the personal wellness. Most of the participants in the grant really wanted to focus on eating more fruits and vegetables. We saw the behavior of those participants, those youth leaders and teachers, increase their own behaviors 81% with eating more fruits and vegetables. And a majority also increased their behaviors, improved their behaviors for the other areas. We were super excited to see hospitals really come on board with promotion. When we first started this, the hospitals said, and I'm not sure what we should do with promoting things in prevention. We're into critical care and treating diseases, and so we worked with them, and they really came on board to the point where they also added some healthy benefits for their employees. Collaboration was a critical piece in this. Kids Club was one of the programs, an exemplary program that was a result of a medical clinic, a hospital, library, and the school coming together to develop some very innovative things. And the quote here, you probably can't see in the back of the room, but the quote really exemplifies how when people create changes in the programs, it also impacts them in their own homes too, something that definitely is a goal. We did see changes in school lunches, but what's more important than the kinds of changes that we saw were the fact that with the healthy changes that school meal servings doubled for each day. They had double the amount of students eating school meals, and that was attributed more to getting the children involved with creating the changes and also marketing those healthy changes to them. We saw that in spite of the wellness policy mandates, that schools are still struggling a little bit, and that it's difficult for them to give up some of their traditions that they had. These on the screen are some of the examples of things that had still been happening in the schools. They changed. The policy was extremely successful once again because they involved kids in creating those changes and deciding what they wanted for their healthy snacks and what they wanted for rewards to replace the higher sugar and higher fat foods that they had in the past. We saw a lot of different changes in practice. This slide exemplifies some of those changes in practice that we saw. What we heard over and over again was, again, that the changes impacted not only the students, the youth, but also the staff. We saw changes in programs. Health fairs are really popular. They're not always interactive and hands-on for the participants, those people attending the health fairs. This slide exemplifies how creative some of those communities became in really getting their health fairs to be interactive. I can't say enough about unusual environments. The libraries really surprised us. Camp Can Do is another exemplary after-school library program that was created in one community. Another library success, I think, really exemplifies what level of capacity building this particular program really had. They came up with their whole items of secrets for success. Collectively, some of the results after year 2, and as I said, we're just winding up year 3, 4 programs reported decreases in employee absences and or health insurance costs. 20 programs reported not just practice changes, but daily practice changes. 13 programs reported environmental changes to support healthy eating and physical activity, and 90% of the grantees reported a high level of commitment to continuing those healthy changes. Challenges that we saw are staff turnovers and broad administrative support, because we struggle sometimes with broad administrative support. We don't always have the time that we need to train new staff as they come in. Bright Promises are studies that are showing benefits of healthy eating and physical activity. We need those to help to commit administrators for their support. We shouldn't lose sight of the fact that teachers and youth leaders really care about kids, and when they're given the time and the resources, they really come through with some things, creative things and ideas to support healthy eating and physical activity. Implications, for lessons learned. We found in the things that we did that our ideas were really reinforced from those outcomes, and we believe that to see continued outcomes, there needs to be support for grassroots efforts. We need to be able to facilitate collaboration. We need to target multiple environments with associated policies, programs, and practices, and support employee wellness. And then just in conclusion, a quote from one of the program participants that talks about CAN being an inspiration to her. don't discount the power of one person. We impact students in programs but in home by these kinds of changes.
Can I just ask you one thing while you're probably not your responsibility, but I was working with former Senator McGovern a couple of years ago on how few cities and states take advantage of the federal breakfast program. Now in Kansas, maybe there are not so many young people who don't, most of them probably get breakfast at home. But in the urban areas, in New York City, for example, I think 90% of the kids get no breakfast at home, and they don't utilize the federal program, which is an entitlement program.
School breakfast is a critical piece to help kids with academic success and for health both. One of the things that we see and we're really working against to dispel the notion that school breakfast is only for kids in lower income. There's a real stigma attached to a lot of kids. They choose not to have breakfast because of that stigma. We're trying to market to schools and programs that all kids can benefit from breakfast.
Yeah, well, there's been a lot of innovation where, so you don't have this stigma where you can, they hand you out these little boxes as you get on the bus and you eat them on the way to school, and there are a lot of things you can do it's understandable that, children don't want to be seen as, poor or whatever.
Yeah, you're very right. There are a lot of different things that can be done, and you gave a really great example. It's just convincing the people to take that step to try something that's been a little bit different.
Like they give you on the airplanes, you give them a little...
Yes, very attractive and fun, yes.
Thank you. All right, Colonel, you're next. A lot of money they don't take. Millions.
Well, I'm so pleased to be here. And when I talked to Senator Dole just a little bit ago, see, he would have to salute me. Now, how's that for a change?
I was only a second lieutenant.
But what I want to... before I start, I want to give you two key points that I want you to consider while I'm doing my presentation. First of all, I want us all to remember that we are all consumers of health care. The other part is that we have to recognize that the majority of us can be without health care in 6 weeks, and we would be out begging for health care like we say those people are, whoever they are. And the reason for that is our health care insurance is tied to our employment. So we can all kind of get off of our high horse and figure out that we're all in this together. So we're all in this crisis together with health care. So my portion to talk to you about is consumer access, wellness, and prevention. And I've already used up 2 minutes here. And I'm going to talk about the challenges and the barriers. And for people that's seeking health care, the challenges and the barriers are about the same. Because what we do is we go into communities and try to tell them what they need to do to have better health. But what we need to be doing is to go in the community and try to change the way the community needs to be changed according to, by asking them, not go in and just say, this is what you need to do. And with that, we can have some ownership by the community. And it has to be broad-based participation. Back in 1996, we were able to raise $2 million from just city and county and business, and we only had one organization out of state that gave us some money to open up the Center for Health and Wellness. And so we used city and county, and Melanie McCrae Miller is here now, and she was on with us back in 1996 when we started trying to raise this money. but it takes the medical community, business people, churches, and individuals if we are trying to build a facility in the inner city so we can change the way people are viewing health care. The other challenge is to foster personal ownership versus just charity. Because if I can only get my health care in a really what I feel is a low-income facility, and I'm going to feel that I'm not getting the kind of health care that I need. And so when we're building the center, and I have to say I am the co-founder, but I'm retired now, and the difference in being retired is I had to do my own slides. So, but I'm going to tell you some things that we learned over that period. That we wanted to make sure that people would have personal ownership for changing their behavior, because we wanted them to go from sick care to well care, so that we could save them before they get to the point of waiting until I have a stroke and then take me to the hospital and charge $300,000 for me to die in 3 weeks. It has not made sense to me. So we wanted to do something totally different from that. So we wanted to have a system where everyone paid, because we didn't want people to just feel like everybody in there was on Medicaid or didn't have insurance, because then they would perceive that the care was not as good as what they were going to get down the street. So that was the purpose of having a really state-of-the-art treatment center with education. As you walked in the door, it was a big education center, so that they could feel that they were going to get the same type of care that anyone else would get. So everyone paid, include creative payment options, and what we did, we had a contract to care. And so in the community that you live in the inner city, urban areas, people know that if you come to the desk and they ask you for your insurance card and then ask you for $2, everybody in the lobby knows you're on Medicaid. They know you're supposedly poor. People don't want that, so they will resist even going in because of that stigma, the same way with the children eating lunch. And we have to try to make sure we're protecting a person's dignity and self-esteem, making sure that their records are confidential, and that everyone in that facility is going to get equal medical treatment no matter whether they have money or not, because we're asking them to change their lifestyle so that they can focus on prevention and take care of themselves and not wait until they're severely, chronically ill. So that was one of the focus, that was the big focus. Prevention, not just treatment. And to give them a chance to have high quality treatment. And the convenient access, I want to talk just a little bit about that.
Could I just ask this question? Mm-hmm. Are there enough professionals that know how to do things for wellness? They all treat sickness. I mean, are there, there probably are that I don't understand, but there got to be trained doctors, nurses, whatever, who are in the preventive medicine or wellness side, because normally they're treating someone who's sick.
Well, that's because we have a sick care system that we all know how to treat well. We know about well care, but no one pays for it. There's no insurance companies, very few that want to pay for prevention. We'd rather wait until, again, at the end, and then pay this huge amount, which makes no sense to me, instead of giving in the beginning to let me know that we're just recently finding out that obesity has so many risk factors for hypertension and diabetes. The things that we die of are preventable. Hypertension, diabetes are the chronic illness that kills us that we can prevent if we know about it. And so we as nurses and physicians, we know what to do, but you just don't have the time to do it. So it needs to be done. And they also need to have convenient access to a place. And access does just not mean, is there a clinic beside me? It means, do I feel good about going in there? Do I think they can help me? So we need to look at that. The hours of operations need to be for the clients we serve, not for the people that work there. And they need to be affordable. So we tried all of those things. And you have to ask the community to get in and invent ways to close the gap. You cannot change me unless you're including me in what I'm making me understand that I'm a part of this, and share a vision with me, build a relationship with me. That's the biggest thing and the hardest to do. And it takes so much time to constantly build and rebuild relationships in the community so people will feel that they can trust you to help them to take care of themselves. And the strengths and capacities of the people in the community is very important. Investment, creativity, hope, and control. If I don't have any hope, I'm not going to be able to do much. Our mission at that time was to provide what I call good enough for me, and we've since taken that out because I was really wanting it to stay forever. But to provide good enough for me family health care for the community through improved access, a heightened and unrelenting focus on education, prevention, and state-of-the-art treatment. That was the reason I was insistent that we have a state-of-the-art facility so that people could feel good coming there. But we know what we do. For whoever those people are, we build some dark, dingy clinic and say, you go there and get your health care, and I'm going to go down here. So people don't like for me to say it, but I say it anyway. And it was really a new paradigm, and we was really focused on prevention and treatment. And since people were already sick, we had to have a clinic area for them to work on their chronic illness, but our real focus was on prevention and wellness and protecting a person's dignity and self-esteem so they could decide if they wanted change. And I've been doing this for quite some time. I hope I look younger than I am. But in 73, the Black Nurses Association in Wichita, we're part of a national program. But our job was to go out and be an advocate for the patients in the community. And we were doing 2 to 3 screenings a year back in, and we've done them every year since that time. We're celebrating our 35th anniversary this year. But we knew and all doctors and nurses know that prevention and having people understand how they can prevent it and what they're going to do, how to take their medicine, but it takes time, and we don't usually have that kind of time or resources to do that. But the Black Nurses Association was one of the major forces behind it because we've been dragging all these chairs around to different churches, doing health fairs all the time. It does no good to tell me your blood pressure is, and that's what we were doing, your blood pressure is 190 over 100. You need to go see the doctor. Well, I may as well tell them nothing because they can't get into a doctor, and now they just have something else to worry about. So instead, we wanted to break that chain. So when we did health fairs, we could take them right across to the door, and they could go in and get some care. And then we could tell them in our health fairs, your blood pressure should be no higher. We just put it on the radio. Know your numbers. Your blood pressure should be no higher than 135 over 85. And so people in the community began to understand that. And so, but just taking it and telling them without giving them a way to get something done about it is counterproductive as I can see it. You may as well not do it. And that's what we do a lot of times across the country. We do health fairs, tell them that their blood pressure is high, and tell them the impossible, go find a doctor. And they can't do that. So that was the other part of having the clinic there so that we could take care of them after we gave them that information. But we were hoping that they would not have that. We were able to, I can't tell how much time I have. Okay. My health
about 30 seconds.
Okay. Just some of the health outcomes that we were able to. We were fortunate to have Dr. Angela Pascal and Dr. Rhonda Lewis. Angela Pascal is a researcher from KU Wichita, and Dr. Rhonda Lewis was from WSU, and she's a behaviorist. So they could help me. I'm telling them what I want to find out. So we were able to do this baseline assessment of the health status of health behaviors of African Americans. We had 150 people in that program. They stayed in for the whole year with 80% of those people still there. And so we were able to prove that people will change, and we gave them activities for life, which was exercise. It took me a while to figure out exercise is a luxury to a lot of people. They won't take it. But we changed it to call it activities for life. You had to come and stay in 3 programs a week. You had to listen to me talk about high blood pressure and diabetes and what you should eat and all of that, but they all stayed. And there was some change at the end for the better. So we know that people will change their behavior. And my policy option, since I'm on the Kansas Health Policy Authority, this is somewhat one of those 21 points. There was no need of coming up with anything else. Everyone needs a medical home. We all have one, a lot of us. But a medical home is nothing more than I have some doctor that I know, and I can call him and say, this is Friday night, I'm sick, what can I do? And he can tell me because he knows who I am. And that's part of a medical home. So we need to develop regulatory definitions of a medical home. We need to pay for prevention, healthy behaviors in families and communities, paying for prevention and healthy behaviors in the schools. We have all these little fat kids walking up and down the street, and it's a train wreck coming. We cannot support them, and we have to say it. But for some reason, we don't want to say it. But as a health professional, it is my responsibility to say, if you keep this up, you're going to be dying early, you're going to have diabetes, and you need to try to listen. I like chicken like everybody else, but I can't have it every day. And so that's the way it is. So we need to pay for prevention, healthy behaviors in school, and we need a national focus on welfare. And we need to stop all this waiting till we're sick. That's what we do. Thank you very much.
We're going to ask that you be promoted to full colonel.
That'll work.
Okay, Ned Holland. Where is that? Oh. Pain free. You feeling okay?
I'm the cortisone guy.
Well, he's going to give us the employer's view on this prevention and wellness. And yeah.
I want to be clear. I actually did have to work with my physician this morning to get here, but let it be understood that no one who grew up in Prairie Village, Kansas, stands up Bob Dole, no matter what the problem. Senator, I want to thank you and your 3 colleagues for the work you're doing in this critically important area. I happen to think it's the greatest problem facing this country in the next 10 years. And I'm particularly pleased because very many of these symposiums exclude those of us who actually pay for health care, and I'm glad to be here and have a chance to talk on behalf of employers. I always have to sort of set my background because I have a very ambiguous background on the healthcare system. I spent 24 years representing doctors and hospitals. I chaired the Kansas City Area Hospital Association. I truly was a leader in the industry. And about 16 years ago, I switched sides and I became a purchaser, and I've now been a healthcare purchaser at 3 successive Fortune 500 companies. That will begin to color your views when you actually write the checks. And of course, in addition to that, I'm a patient, a consumer of healthcare. My insights on wellness programs come from my experience at Sprint and at Embark. Embark is a spin-off from Sprint. We spun off 2 years ago. Before I left Sprint, I was purchasing healthcare for about 80,000 employees. At Embark, we purchased for about 20,000 employees. If you want to think about the number of lives, you take either of those numbers and multiply them by 2.25 or 2.5, and that'll get you up in the 200,000 lives arena at Sprint and 50,000 or so lives at Embark. We care a lot about what is happening. The short answer to the inquiry about wellness programs is that they're the right thing to do, a bit like motherhood and apple pie. But unfortunately, they don't really solve the problems we're looking at. They don't convince any CFO I've ever talked to, and they are absolutely not the silver bullet for reform of the healthcare system in this country. They do, I think, meet the admonition attributed to Hippocrates, first do no harm, and therefore we ought to do them. But I think to rely upon them as the ultimate answer to healthcare reform would be a mistake. Let me describe to you Embark and Sprint, and I'm going to mix them up because I won't try to tell you what we did at one and what we do at the other. But generally, we are self-insured. That is, we take the risk. And we have multiple plan choices for our employees, up to 5 in some markets. So an employee comes to work for us, and he or she gets to pick from 5 different alternatives. We have our own indemnity plan. We have a PPO. We have an HMO, a nationally rated HMO. We have a so-called HPN, which is a high-performing network. And we buy from several commercial HMOs. So our employees have choices. And they get that choice every year, and they covet that choice. But I can tell you that virtually, certainly, I can guide their choices by lowering the premiums, no matter what I do in the back end with fees. They look to the premiums, what comes out of their paycheck every 2 weeks, and that's the plan they'll go to, and I've experimented with it, and I've seen it work. Let me talk a little bit about the micro designs of our wellness programs at Sprint and Embark. We, for years now, have had a non-smoker's premium, a special premium. But what do we find? Many people don't even bother to take it. We know we don't have as many people smoking as our plan would indicate, so people don't take the time to take the benefit of the non-smoking premium. We built an on-site clinic at Sprint 5 years ago, by far the first in Kansas City. It was an enormous success. It saved money. It was a great service to our employees, but only about half the people who could use it did. We have nurse advocate lines to help employees when they're on that Friday night when they're sick if they can't find their own doctor. But the nurse advocate lines are used by about 5.8% of the people who are eligible for them. We do health risk assessments, and we offer credit cards and credits and gifts for people to use the health risk assessment. This year, if you take a health risk assessment at Embark, next year you'll have $250 off of your premiums. But we get 14% take rate. 14% use it. We do complex case management. So when you get trapped in this healthcare system is maybe a misnomer, when you get trapped in the healthcare system, you need help navigating it. And it would behoove all of us to have somebody help them find the way through it. But we get 0.1% participation in our complex case management. We do cancer screenings free. We do on-site barometric screening. For the future, frankly, we're beginning to think about sticks rather than carrots. So we've been discussing within the last 10 days, in fact, our design for next year's healthcare plan. We may be pretty aggressive. Maybe, for example, if you refuse to do a health risk assessment, we'll decrease our co-insurance to 50% from the 70 or 80% it normally is. Then a disease management, if you refuse to use it, maybe we'll increase your deductible by 2 times. Maybe we'll have the plan pay only 60% co-insurance. Those are the kinds of things that we're looking at because it appears to take more than just a little incentive to get employees to use them. And what about the return on our investment? First of all, the calculation of the return on investment of these programs would make calculus look like child's play. It just isn't all that easy. But we believe that over the next 3 years, we're going to save about $8 million because of our wellness programs that are operated by a national provider. Unfortunately, we only get, unfortunately, we're looking at utilization that is going up 15 to 20% a year. Our trend is over 15%. So we have to wonder whether it's going to work. But it does no harm, and we'll stay at it. But when I'm looking at a healthcare plan that costs $150, $160 million, saving of $1.2 million or something like that, while not unimportant, and certainly as a friend of mine would say, more than I have on me, it doesn't fundamentally move the needle. In addition, we've got a real question. If my employees do use all these fancy programs and begin to get healthy, but with normal turnover, they go down the street and they work for Hallmark, or they work for General Motors, or they work for any one of the number of smaller businesses, who benefits? Do my shareholders benefit, or do somebody else's shareholders benefit? And frankly, my fiduciary duty runs to my shareholders, not Hallmark's or Cerner's or anybody else's. In addition, we receive complaints from employees. I've gotten screaming emails. Our employees can always find me. I get screaming emails. This insurance company called me. What businesses are theirs that I have X, Y, Z problem? Get them to leave me alone. I will talk to my doctor. Well, if they talk to their doctor soon enough, they might not have the problem they have. But that's how employees view these programs. They just want to be left alone. I've been working for a couple of years on a program with the California Healthcare Foundation, a not-for-profit foundation, much like the Kansas Health Foundation, that does lots of work in the arena. We tried to do some basic consumer market testing. We're marketing something to our employees. We should use consumer testing kinds of devices, and we have. The work that they've done shows very clearly that there are two groups employees don't want to hear from. They don't want to hear from their union, and they don't want to hear from their employer about their health care needs. We have to find some other way to educate them. The real problem, frankly, this is a bit of the cynic in me, but our employees, like many employees in the country, I think, and many people in the country, are in a continual quest for the fountain of youth. And in pursuit of that, they want everything they could have, they want it right away, and they want it free. And that just doesn't happen in my world. If we are going to solve this problem, we have to have far more fundamental reform. And while I'm not particularly enamored of insurance even as the model, we use insurance as the model in this country for a system that really you can quite carefully project what it's going to cost you. There's no real underwriting like there is in fire and auto and casualty insurance. There's a projection of use. The Blues started years and years ago when they said they were a prepaid healthcare plan, and that's really what we're doing. But about 15% of our employees consume about 85% of our health care, and that's true nationally generally as well. We have about 10% of our population that doesn't use the system at all. Almost everyone agrees that a huge amount of the health care is unnecessary. Somewhere between 30 and 50%. I've heard as much as 50. I heard Chris, I think, say this morning 30. It's in that ballpark. We need some key things for reform, Senator, and let me just suggest them. First of all, we need an information technology platform that will really support what we have to do in this country. It doesn't exist, and I keep hearing doctors and hospitals say they want to get paid to put it in. Frankly, I fly all the time. I don't pay extra for planes that don't crash. I expect them not to crash. We also need quality standards. We do not have general quality standards, and we need to work on those, and I'm involved in several efforts to do that, and I know that is core to what the Senator and his colleagues are looking at. And finally, we need appropriate reimbursement incentives. So let me give a couple of specifics. I think, for example, we pay doctors wrong. There's a thing called RBRVS, Resource-Based Relative Value Scale. And it pays doctors with procedures more than it pays doctors who do cerebral medicine, who diagnose and suggest the procedures. That's a bit like paying the mechanic more than you pay the designer. That seems to be a mistake. We don't pay physicians to do things efficiently, like email and telephone. My doc will talk to me by email and telephone, but he's a rare exception. They don't get paid for that. That is ridiculous. When I talk to my lawyer, I get charged for the first time I get an email from him. We need to substantially increase coordination of care. And I'll give you stories, but the truth is that the care is so fragmented that the person dealing with you the first time doesn't talk to the person dealing with you the last time, and what's lost in between, heaven only knows. We should not be paying for medical errors. The system is full of medical errors. There's something called never events. You're beginning to see the government and healthcare providers, insurance companies saying, no more, we're not going to pay. No place else you get a bad outcome and then have to go back in and pay to get the bad outcome fixed. That's a mistake. We need to change that. And we need to arrest the growth in the system. The way to find a hospital in Kansas City is to look for the construction crane. No problem finding it. I can go to my office at I-435 in Knoll. I can look out the window and see at least 6 specialty hospital clinics. We don't allow those in our network, by the way. But they're there, and they're expensive. I heard some little talk about it a bit ago. We did a study at the Kansas Health Policy Authority, on whose board I sit, and it demonstrated pretty clearly that what the new doctor-owned clinics do is increase demand. This is the one area of the economy in which supply drives demand rather than demand driving supply. And competition has never worked to drive down costs in the healthcare industry. Uwe Reinhardt, the famous economist from Princeton, said it perhaps the best. He wrote a long article a couple of years ago in Health Affairs. It was entitled, "It's the Prices, Stupid." So we need to listen to Reinhardt and others. We need to look at alternatives at the Health Policy Authority. we did a very careful study done by a fellow named Steve Schramm, paid for by several of our local foundations. And he looked at what would happen if Kansas did like Sprint does or like Embark does and self-insured all its population, all the residents can. What if we just self-insured like big employers do? Well, that sounds like socialized medicine, of course, but let's just suppose we did it. The model suggests that we could save $1 billion a year in Kansas on about an $8 billion base if we would self-insure and do health care like employers do it. Unless we have real fundamental reform, I frankly think we need to get employers out of the business. My fiduciary responsibility is to my shareholders. They are the people who hire me. They are the people who put me to work. They are the people who expect me to shepherd their resources. I've been in corporate America now after I left my practice of law for 16 years. I have never had a budget challenge that was any different than flat or down. But then I had this piece of the budget called healthcare, which was always up and up and up. I can't explain that to a CFO. I can't explain it to a CEO. We need to find a way to stop that so that I can actually say to my CEO, okay, flatter down next year in healthcare too. We can take a lot of different approaches. There could be a federal approach. There could be a state approach. There could be regional approaches. There could be even a robust individual market. Any one of those would be fine with us. But if we can't make one of them work, you're going to begin to find employers, just as they've already doing, bailing out of the retiree healthcare business. More and more people are without retiree healthcare. You're going to begin to find employers getting out of the direct active healthcare business. And frankly, I don't think that probably bodes well for the system, Senator.
Thank you.
Thanks, Ned. Very good.
Ned, thank you for that uplifting assessment.
Always happy to be of help, Chris.
Could have given you a little bigger shot.
Can you write the script, Senator, for me?
One thing that I think actually Ned raised, and Arnithia, I'd like you to respond to, is this whole issue of even if you do have wellness programs in place, even if you do cover prevention, the motivation to use them, number one, and how you best can do that. And then also, what are the barriers? Why aren't they using them as much as they should? And do you agree that they're not the magic bullet for our healthcare system?
I think one of the issues is getting the employees involved in the kinds of benefits that they want to see for employee wellness, such as what Arnitha had referred to. You have to get everyone involved. I think what tends to happen a lot of times is that we provide things and people, they aren't necessarily meeting people's needs. In other cases, I think it's the time factor. We all live in a very busy, time-driven world, and I think employees, as well as everyone else, don't always take the time for that employee wellness.
Would you all believe that Ned and I are on the same committee, the Kansas Health Policy Authority? We have a great time. The question that you're asking, I think if we're building communities from the inside out, we're always trying to build them from the outside in. That work, as Ned has said. And it will save us resources. There's studies out there to say that prevention and wellness saves you resources after a few years. But we don't want to wait that long a time. We want it to work like that, and it doesn't. But if we invest in it over a long period of time, and we know we have research to say those risk behaviors, those obesity and high blood pressure, preventative diseases can be pushed back and save us money. So they do work, but it takes a while, and we just happen to be able to get the Sunflower Foundation to give us a grant when we were doing that assessment. So otherwise, we wouldn't have that proof that it does, that at least for that small sample, it works. If we had plenty of money, we could probably prove it even more with a larger sample. But I think it works, but we have to ask the community. We can't go in and tell them this is what we think will work. Maybe they have a better idea.
Well, I was going to ask the question of Ned. Because I think a lot of things he said, I think are some of the real problems out there. How do you get people interested? What incentives does it take for people to take an interest in prevention or wellness, or until you get hit with that big hospital bill that you're talking about? We have sick care instead of well care. So, are you making any headway at all, Ned, with the incentives you offer? Or?
Some, Senator, some. It's not all doom and gloom, but we've literally spent millions of dollars communicating with our employees. Letters, videos, brochures, meetings. We do lots of stuff to get them interested. And frankly, most of us think we're bulletproof until we wake up in the morning and our back hurts. And I actually knew I had the bad back before I went to bed last night. But so I think it's going to take a long time. Arnitha's right; it doesn't happen overnight. And I've been working on wellness programs for now almost 10 years, and there isn't a big take rate. When we get 14% of the people doing health risk assessments, why do they not take it? Because they're afraid I'm looking over their shoulder. They don't trust their employers. No, we're a pretty good employer, frankly. I trust my employer, but I don't think our people do. I really believe that ultimately we have to get everyone in the risk pool together. That's part of the problem. I have 50,000 people I'm responsible for. Somebody else has, Cerner has, I think I heard the gentleman say 20,000 or something like that. Those numbers sound big, but they aren't big enough to move the market. When I was at Sprint, I bought health care for 2.5% of the Kansas City area market. And the hospital said, Sprint who? Because we just aren't big enough. So I think it takes a broader risk pool. I think we need to expand it and keep it big. Once everybody's in it, then programs like these will begin to work. And I won't be worrying about whether my employees go to Hallmark or to Cerner, because I'll get their employees back and we'll all have been in the same risk pool together.
I have just one example. When you go to the hospital and experience sick care, people send you flowers. They come by and see you. When Melanie and I are out doing our 5-mile run in the morning, walk, to try to stay healthy, people just look at us and say, what are you doing that for? So it has to be a whole
You got the
paradigm.
dogs chasing you too. Yeah.
But you get no incentive. You have to know that, and I think that's the big difference. We pay many ways for sick care, and we give you all kind of flowers if you're sick, but if you're well, nobody gives you anything.
And I'd like to just add, too, when it comes to kids and youth programs, kids really watch what adults do. They learn from adults, and employee wellness is one of the ways that people can model to kids.
Well, it seemed to me that, I don't know what the Kansas media does, but it seemed like there's an opportunity here for radio, TV, particularly kids programs or older people programs on some of this. Some people never get the message. I mean, there are always a few that could, they don't know what day it is. So, but that's going to be the job that the next president's going to have. I mean, how's he going to put all these things together? And I don't think you're going to put them all together. It's going to be more than a one bill approach. It's going to take some time, and if you could turn all these special interest groups loose, unless you act pretty quickly, it probably won't happen. And I don't know, somebody asked me in an interview a while ago, only 14% of the people say health care is a problem. Well, that's probably because they're not sick the day they took the poll. So they put the price of gasoline or a rock or something else. But my view is it's the most important problem. I mean, someday you're going to deal with it. And it's like this 47 million uninsured. 10 or 11 million of those are young people who don't think they're bulletproof, as Ned said. We don't need to spend money, I'll buy a new car. And another 10, 11 million are illegal. So they're probably 25 or 30 million people that we really got to figure out some way to help. And It's not going to be easy.
And I have to ask the question about the pulling all these little different pieces together, and they're all hard. But you talk about this issue of quality and value and cost, and I think that's a huge component. The one thing that seems to be uniting us in this discussion with Republicans and Democrats and purchasers and even providers, primarily because they're worried about the unsustainability of this cost that Senator Dole talks about, is the healthcare infrastructure, trying to figure out some way to do the information platform you were talking about, Ned, using the IT, et cetera, information technology, combined with quality standards, combined with reimbursement incentives, to really drive value and quality. And then, though, and when we talk about prevention, they say, but if we don't have everyone in the system, what ends up happening is you don't have the desire to invest in a lot of those things. And I'm wondering if you feel that the integration of everyone in the system, as you were suggesting, helps actually facilitate being able to improve how we deliver care more efficiently and more cost effectively.
I do believe that, Chris. I think one of the problems we have with the system is that people move in and out of it sort of willy-nilly as meets their current need. I've got 3 kids in their 30s, and they think they're bulletproof too, Senator. They won't be. And I think if there was some way to return to community rating, I mean, we used to do this. Blue Cross Blue Shield, which was the original, the granddaddy of all healthcare plans, did community rating. And you were in the system, and everybody was part of the system. Now, we did a lot of things to fracture that over the last 50 years. But I do believe that there is something to community. Now, our culture, and I'm cognizant that I'm out here in the middle of Kansas where I grew up, our culture is still sort of cowboy and Indian culture. Take Japan, where there really is much more homogeneity, and what you'll find is that they have better results than we have, by a lot. We spend more than anybody else in the world on healthcare, but our outcomes put us in the 30s or so on most measures. Why is that? Well, it's because we don't have everybody in at the same time.
Do you want to comment on that?
Well, I guess I agree with what Ned is saying, but if it took us a long time to get to the point of where we are now, with people just utilizing sick care, but we're going to have to change around and try to deliver well care, starting with when you're in the first grade. They have all that sweet stuff in the schools, and kids are fat, and they're going to die, and we know it, and I'm scared about it. I really am. So we're going to have to keep saying it. We have to change the way we're viewing health care. And we probably shouldn't even call it health care. It should be well care. And that's the problem. We give it a name that's for when wait till you're sick, and the doctors tell you the same thing. Don't call me about any well care because I don't have time. And then that's our big issue.
Arnitha and I spent a lot of time talking to each other, and I do agree with her about those things. However, I think we ought not kid ourselves. We could make everybody as healthy as possible, and the human condition is not immortal. We're all going to die sooner or later. And my mother died a few months ago. She was 89 years old, and the amount of money we spent on my mother in the last year of her life was really obscene, to no particular value. Didn't make her more comfortable, didn't make me feel any better, but that's just what the system does. So we're still, no matter how good we get at teaching and preaching and leading wellness, we're still going to have to take care of that part of the system. We can't ignore it. And that's my point about wellness is not the silver bullet.
That's where the big cost comes in the last, 2 years, 3 years?
Yeah.
3 months.
3 months of your life.
I once read the statistic that 40% of the federal health care dollar is spent in the last 2 weeks of people's lives. I don't know whether that's accurate or not, but it's a big number.
Yeah, that ought to give you notice. Yeah. Okay, well that concludes this panel, and we're going to have a little 10 to 15 minute break, and then we'll wind it up. Thank you very much.